is probably the most important part of mechanical ventilation because it concerns every patient on the vent. And try to give you some views about why we absolutely need to think about weaning differently and why a classification may be useful. These are my conflict of interest. So the ideas, if you look at the literature on weaning from mechanical ventilation, you may see very, very different questions addressed and very different clinical scenarios and very, very different outcomes. However, the guidelines, protocols, recommendations tend to put every patient in the same bag, saying this is how we do weaning, we should do weaning. Although it's a good idea to think about having recommendation, I think not making distinctions makes things very confusing. So this idea started with this task force in 2007 and trying to simplify a little bit the general problems associated with weaning. And saying if you look at patients separated from the ventilator, and if we forget now the patients who are never separated, there is a first group of patients who are simple. Simple means the first attempt to separate the patient from the ventilator will work. So you could say, okay, this is not a clinical problem, let's go to the second one. Well, this is the opposite. This may be the biggest clinical problem in terms of number. Because in this group of patients, the key issue is how do we detect as early as possible that these patients are ready. And this is a policy issue for your ICU. This is where most of the protocols have made progress in terms of duration of ventilation. Because if every single easy patient can be separated 1 day earlier or 2 days earlier, you save a lot of ICU days. But this is very different from the second group of patients who do not succeed at the first attempt and needs repeated attempts, maybe let's say up to 1 week. And in this group, the clinical problem is completely different. The clinical problem is why is this patient unable to breathe on his or her own? What is the medical reason? What can we do to improve this patient? So what are the reasons for failure? And then you have another group, which are patients, and that's a bit arbitrary, but say after 1 week of repeated attempts, the patient is still stuck on the ventilator. These patients become ventilator dependent. They are prolonged ventilation. They are called by different names in the literature. They are the kind of chronically, critically ill patients which we describe. And in these patients, maybe they are tracheostomy, they are, the main problem may not have to do, or very little, with the ventilator. It mostly have to do with the global management, including sleep, mood disorders, nutrition, of course, rehabilitation, etc. So, again, putting all the patients in the same category called weaning from mechanical ventilation makes little sense, and I will try to show you some data. There have been a number of studies looking at that, but the problem was the initial description was mostly a theoretical concept. And so the study which tried to apply this definition had to decide on different way to make this classification, so the results are not all consistent. In general, they tend to show that the simple weaning is a larger group of patients. And they also showed that the third group, the prolonged weaning, are patients who have a higher mortality. But it's a little bit biased because by definition, this classification only look at patients who are successfully weaned. So a few years ago, we decided to have a large prospective epidemiological study about weaning and trying to see what could mean this classification in terms of different group of patients. So with the RIVA network in France, we decided to have this epidemiology of weaning outcome according to a new definition, so the WIN study, because we thought this where the answer was blowing. No, not exactly that. And we say, let's look prospectively at all patients under mechanical ventilations. And let's try to make the definition operational, so not only theoretical. We say, maybe to make it simpler, let's separate the patients. First, of course, we look at all patients. So we look at patients who have separation attempts, and of course, there will be a certain percentage of patients who never have any separation attempt because they will die in the ICU. Then, for the first group, we say, let's look at patients who have weaning terminated within 1 day. It takes 1 day, whether it's successful or not, but it takes 1 day. Then, let's look at patients who take between more than 1 day but less than 1 week. And then patients who are still on the vent with repeated attempts after 1 week. Okay, 3 groups, let's say simple, difficult, and prolonged. This is the distribution of the 3 groups. First group, so sorry, there was something like 2,700 patients enrolled from more than 35 centers in France and several cities in Europe. So the first result is that 70-75% of the patients are group 1. So again, this reinforces the fact that in this patient, the early detection of separation is very important. It also tells us that a lot of weaning trials, weaning studies, are heavily influenced by this first group. And the result of the trials we have may not apply to group 2 or group 3. Group 2 is about 15%, group 3 is about 15%. When you look at the characteristics of this patient, I'm just showing you here the hospital mortality. It's very, very different groups. First group, of course, it's very low mortality. Most patients will be discharged from the hospital. Second group, the mortality is already 3 times higher. And the third group, the mortality is close to ARDS. So that's really very different group of patients with very different clinical problems. And if you look at the distribution of ventilator-free days for those who are used to that, you usually have a peak here, which are patients who die during the first 28 days, and a peak at the end, patients who are easily separated. But you see that this is mostly influenced by group 1. Group 2 and group 3 have a very different distribution, and much less, of course, by definition, high number of ventilator-free days. And lastly, I would say, if you think of the risk for patients failing the first attempt at separation from the vent, we try to illustrate that by showing the daily probability of hospital death. And you see that immediately after the first failing attempt of separation from the vent, the mortality will go up. There is a kind of plateau in the first week, which that would be a difficult weaning group, but after that it goes up, and at 10 days, mortality is close to 40%. So really we are dealing with a lot of clinical problems. So doing this approach and this weaning classification also help us to address specific questions which are not usually taken into account in in guidelines or recommendations. This is the overall characteristic of the population. You see here that the overall rate of reintubation is less than 10%. There is approximately 11% of patients who receive post-extubation NIV and 13 patients who have a do not reintubate order. These numbers will vary a lot depending on the group, of course. Then we say, what are the factors associated with a shorter duration of weaning? So we just separated patients between short weaning and longer weaning, including group 2 and group 3 together. And these are the univariate and then the multivariate analysis indicated here. You see that age, severity score at admission, either SAPS-2 or SOFA, and the kind of medical versus surgical admission made a significant difference. We tried to ask for every patient, was there a sedation protocol which was used? Was there a weaning protocol which was used? The sedation protocol was significantly associated with shorter duration in univariate analysis, but not in the multivariate analysis. The weaning protocol was never associated with a difference in the duration of weaning. Then we also look at the way patients were managed after a spontaneous breathing trial. And to our surprise, we realized that only 60% of patients are extubated right away after a spontaneous breathing trial. So 40 patients pass the SBT but are not extubated. I think it's a very interesting question why this really large group of patients have a delayed extubation. Is it good? Is it bad? I think we cannot answer now. We need to address this question. To our surprise, we also found that 11% of patients were extubated without any SBT. And of course, the dogma today is to say you need to do a spontaneous breathing trial before extubation. And I think this is a very important question. Of course, it corresponds to different kinds of patients. When we look at patients who were extubated without an SBT, we found 3 different kinds of patients. Patients with unplanned extubation, of course, easy to understand. Patients who had do not resuscitate order or decision of withholding withdrawal, who were extubated without probability of success assessment, but also a significant number of patients who were assumed by their physician to have a high likelihood of weaning success. The pre-test probability of success was so high, they say they don't need SBT. Did these patients, what was their outcome? Was the decision of the physician stupid? Well, if you look at the reintubation rate in those planned extubation without SBT, it was almost lower than patients with planned extubation after SBT. And if you look at the mortality rate, it's almost 0 in the 2 groups. So I would say the clinicians were probably wise to say these patients even don't need any SBT before extubation. I recently saw presented at this meeting a large randomized control trial where the rate of success of the SBT was 92%. When I see that, I say, do they need any SBT? Maybe you can just miss some patient and have a negative decision, whereas if you know that 92% of the patient will do fine after extubation, I don't think you need SBT. I'm just trying to send some message to say all this individual decision cannot be put in one package. And the third group, I think I have no time to go into detail, but this is an extremely important group, the group which stay on the ventilator at least more than 1 week. You see that in our study, 62% of these patients had successful weaning at the end, but 38 patients were never weaned. So they either died in the ICU, were transferred under mechanical ventilation, or were still under mechanical ventilation at day 60. So I would say in conclusion that why do we need to work on this kind of weaning classification? Because weaning is too complex and too diverse to be considered as one single question. The 3 groups classification distinguishing 3 different groups, it might help for future trials and also for presentation, for recommendation. Thank you very much.